Hey everyone, and welcome. We're about to dive into a clinical briefing that's absolutely essential for your pediatric rotation, reproductive and genetic disorders. Knowing how to spot these conditions is a skill you are going to use every single day. So let's just get right into it. Okay, let's start with a scenario. You're in the peds emergency department, and a child comes in complaining of groin pain. Right away, your brain needs to start firing. What are the possibilities? Is this a simple muscle strain, or is it something way more urgent? Knowing how to tell the difference and how fast you need to act is everything. So, what's your next move? Let's break it down. First up, we're going to tackle reproductive health in our female pediatric patients. Let's take a look at some of the most common issues you're likely to encounter. All right, so a straddle injury. Think falling on a playground bar or a bicycle. It looks scary, but it's super common and usually resolves all by itself. Then there's vulvovaginitis. You'll see this one a lot. It's often caused by simple irritants like bubble baths, wearing tight synthetic clothing, or even just improper wiping. Sometimes pinworms can be the culprit too. Now, for adolescents, bacterial vaginosis is the #1 cause of discharge. And, of course, you'll see abnormal bleeding. This can be amenorrhea, which means no period by age 16, or menorrhagia, which is that really heavy, prolonged bleeding. For a lot of these, your most important job is education, talking to patients and parents about proper hygiene and clothing. Okay, let's switch over to our male pediatric patients. Now, this is where your sharp nursing judgment really comes into play. You have to be able to distinguish between conditions that are totally normal and just need some observation versus the ones that are true medical emergencies. So, a lot of the common stuff falls into this watch and wait category. Take physiological phimosis. It's just a normal inability to retract the foreskin in little ones. The absolute key takeaway here is you do not force it back. For cryptorchidism, an undescended testicle, or a hydrocele, a fluid collection, the body often sorts itself out in the first year or two. Honestly, a huge part of your role here is just being that calm, reassuring voice for some very anxious parents. And then we have a varicocele. Now, this one has a classic description you need to lock into your brain. It's a painless collection of twisted veins, and on palpation, it feels like a bag of worms. It's a weird description, but you'll never forget it. While it's not painful, it is something to keep an eye on because it can be linked to infertility down the road. Okay, deep breath. We are shifting gears hard from watch and wait to act right now. This is our first true emergency. Testicular torsion. Look at how that spermatic cord has twisted on itself. Why is that so bad? Because it completely cuts off the blood flow to the testicle. This is a huge, huge problem. I cannot say this loudly enough. This is a time-critical surgical emergency. From the moment that pain starts, you have about a 6-hour window to get into surgery and save that testicle. Every single minute counts. Time is tissue. So what are the red flags that should be screaming at you? The hallmark is abrupt, severe, constant pain. It is so bad that it often causes nausea and vomiting. When you do your assessment, you might notice the testicle looks like it's sitting higher than the other one, and the scrotum will be swollen and incredibly tender to the touch. If you see this collection of symptoms, you escalate immediately. Another one that can be an emergency is an inguinal hernia. This is where a piece of tissue, usually intestine, pokes through a weak spot in the abdominal wall. The most important assessment question you need to ask is, can you reduce it? If you can gently push that bulge back in, we call it reducible. But if you can't, it's incarcerated. And that's an emergency because, just like with torsion, the blood supply could be getting cut off. All right, now for 2 congenital anomalies you'll definitely see, hypospadius and epispadius. This is all about where the urethral opening is located. I've got a super simple way for you to remember it. Think hypo for low or below. That means the opening is on the bottom or the ventral side of the penis. And think epi for above, meaning the opening is on the top or the dorsal side. Easy, right? Now listen up, because this is probably the single most important, testable, real-world piece of information for these conditions. You absolutely must make sure that circumcision is delayed. Why? Because the urologist is going to need that foreskin to do the surgical repair. This is a critical piece of communication for the family and the entire care team. Do not forget this one. Okay, let's switch gears completely and talk about congenital infections. These are the ones passed from mom to baby during pregnancy or birth. We're going to focus on a really big one, syphilis. So the really tricky thing about congenital syphilis is that a baby can have it and show 0 symptoms for up to 2 years.
But when symptoms do show up, you might see this persistent nasal congestion. It has a nickname, the snuffles, plus a very distinct rash on the palms of the hands and soles of the feet, and an enlarged liver and spleen. But the truly scary part is the potential for central nervous system involvement, which can lead to seizures, major developmental delays, and even hearing loss.
All right, we are on the home stretch. Let's dive into our final section, decoding genetic syndromes. We're going to do a kind of rapid-fire review of the key signs and nursing priorities that you absolutely have to know. First up is the one you've probably heard of most, trisomy 21, better known as Down syndrome. It's pretty straightforward genetically speaking. It just means every cell has 3 copies of chromosome 21 instead of the usual 2. And it does have a known link to advanced maternal age, which is typically considered anyone over 35. So here are the hallmark physical traits you'll learn to recognize. Things like a flattened nasal bridge and those beautiful, upslanting, almond-shaped eyes. A really key finding is hypotonia, or low muscle tone. These babies feel very floppy when you hold them. You might also notice a single deep crease across the palm of their hand. But most critically, and this is a big one for your nursing assessment, about half of all babies with Down syndrome are born with congenital heart defects, so your cardiac and GI assessments are an absolute top priority. Now, that low muscle tone and a relatively large tongue can create some pretty significant feeding challenges. So what can you do to help? These are your go-to interventions. First, position the infant upright to cut down on the risk of aspiration. Second, you can provide gentle support to their cheeks to help them get a better latch. Third, pace the feeding. Tip the bottle down every so often to give them a little break to breathe. And fourth, you are always monitoring their breathing and color for any signs of fatigue. Okay, these next 2 are tough. Trisomy 18, or Edwards syndrome, and trisomy 13, Patau syndrome, are much more severe. For trisomy 18, you'll see things like rocker bottom feet and clenched hands. For trisomy 13, a cleft lip or palate and extra fingers are common. For both of these conditions, the survival rates are extremely low. So your nursing focus shifts dramatically. It becomes all about providing comfort, support, and end-of-life care for the baby and the entire family. Next, we have Turner syndrome. This one only affects females, and it's caused by a missing X chromosome. The hallmark signs you'll notice right at birth are a short, webbed-looking neck and lymphedema, which is just that puffy swelling you see on their hands and feet from fluid buildup. Later in life, these individuals will be infertile and will need estrogen therapy. 2 other important sex chromosome variations to have on your radar are Klinefelter and Fragile X. Klinefelter syndrome affects males who have an extra X chromosome, so XXY. It can cause sterility and some more female-like body characteristics. Fragile X syndrome tends to be more symptomatic in males, and it often presents with a long face, large ears, and some significant intellectual and social challenges, sometimes including autism-like behaviors. Now, this next one is incredibly important to clarify. Fetal alcohol spectrum disorder is not a genetic condition. It is caused by the toxic effects of alcohol on a developing fetus. Physically, you're looking for signs like a thin upper lip and a flattened mid-face. Neurologically, these kids often face developmental delays and ADHD-like symptoms. And from a nursing perspective, a key challenge is helping them manage their feeding difficulties, which stem from poor suck and swallow coordination. Okay, we've covered a ton of ground, so let's recap the absolute must-knows from this briefing. First, know the critical difference between a watch-and-wait situation and a surgical emergency like testicular torsion. Second, burn this into your brain. Delay circumcision for hypospadius and epispadius repair. Third, get comfortable recognizing the hallmark physical signs of these major genetic syndromes. And finally, master those hands-on supportive care techniques, especially when it comes to feeding. We've gone through all the clinical signs, the assessments, the interventions, but I want to leave you with one final question to really think about as you start your careers. Beyond the diagnosis, beyond all the tasks, what is the nurse's most important role for these families who are navigating some of the most complex and frightening conditions imaginable? Answering that, that's what separates good nursing from truly great nursing.